Our next talk is again by our honor speaker, Dr. Richard Fessler, on advances in endoscopic lumbar fusion. Bring it back a little bit.
Good morning, everyone. Great to see you. So in order to talk about advances in endoscopic surgery, we really need to know what we mean by advances and where we started. So first of all, these are my disclosures, and they are relevant. The yellow ones are relevant because in the second half of the talk, I'll be talking about devices that I'm co-inventor of. So I'm obviously have some bias in that regard. So we first started doing minimally invasive T-lifts in 2002, and very quickly developed the technique that I've then used for the last 20 years until about 2 years ago. And my procedure in taking care of these patients is very routine. We have our specific indications that we feel a T-lift is good for. We go through a routine differential diagnosis with each patient, and probably the biggest one there is the SI joint or hip disease. But we go through each of the entire differential diagnosis each time we talk to a patient. And then I talk to them about what we have to do before we can do surgery. Most insurance companies now will not let you do surgery if you haven't had physical therapy. Not all of them require an epidural steroid injection, but you can't do surgery if you haven't done PT. So they have to go through all of those kind of things. And there are other options other than the routine, analgesics, physical therapy, and epidural. You can try traction, you can try chiropractic manipulation, acupuncture, various other types of pain injections. Then they go through a very thorough pre-op evaluation. This has modified all of my patients now get full-length scoliosis x-rays because my practice has evolved to do a fair amount of minimally invasive scoliosis correction. And then we talk about what the options are for surgery. T-lift is only one of the options that we can do. We can do A-lifts, we can do O-lifts, we can do L-lifts. We theoretically could do a transverse process fusion, but I'll be honest with you, I haven't done a transverse process fusion in at least 25 years. We could simply do a decompression. We can use an open or a minimally invasive technique. I'll also be very honest with you, I have never done an open T-lift in my entire career. Or we can continue with non-surgical management. And then we talk about what to expect post-operatively, how long they're going to be in the hospital, what they can expect post-operatively. We do paraspinal blocks, so post-operatively our patients have essentially no pain. You have to tell them that wears off in 24 hours and they're going to be in a lot of pain the day after surgery. If you don't tell them that, they show up in the emergency room. What their schedule is for returning to clinic, who's going to see them, and who's going to participate in surgery. Since I'm an academic center, it's not infrequent that I'll have a patient say, only you can operate on me. I don't want any residents, any students. And I'm very clear with them. I teach people how to operate. If you don't want a resident to be participating in your surgery, you got to go somewhere else. And then we talk about the complications. And this is my routine list of complications that I deal with, give to every single patient. And it's interesting, we talk about pain, and I tell every patient the same thing. We're going to start physical therapy at 6 weeks. At the end of physical therapy, you will be 50% back to normal, and that's 3 months after surgery. 6 months after surgery, you'll be 90%, and 100% takes a full year. So then we did a study, and we asked them what their perceptions were of how long they're going to have pain and how long it's going to take to get back to normal. Even though I tell every patient exactly what I just told you, their answer was 2 weeks. So they don't hear you. So here's the surgical technique that I've been using up until a couple years ago for the surgical technique. We published our first series in 2005. So we modified our approach to go a little bit more lateral than the PLIF, the P-lift. So the complication rate, lowest complication rates in the best hands with PLIF was 5% neurologic complication rate. With T-lift, you can drop that to a decimal point. So I typically would make a 3-centimeter incision because I want to have access to the top of the pedicle above to the bottom of the pedicle below the level I'm doing the T-lift at. And then we would dilate down, and through the tube, do a first defined sublaminar space. So when I'm teaching residents, the residents now always want to grab the drill immediately. So they take all the muscle and all the fat off, they grab the drill and they start drilling. The problem is they often don't know where they are. A couple years ago I was doing a thoracic disc, and an experienced resident drilled off the contralateral rib head. So I force them to use a Kerrison punch and a curette until we start doing the facetectomy, because a drill will drill whatever you put the tip on. You can't do an incorrect bite, other than getting a drotomy or something like that, with the Kerrison. You've got to be in the right place. And that way you know what you're doing. And so I force them. So I then do osteotomy with this. I tried doing the scalpel, the harmonic scalpel. It doesn't really work very well in a tube. First of all, it's big, so you can't really see around it very well. And of course, it's irrigating at the same time, so you got to have a sucker in there, and it doesn't work very well. So I've gone back to doing this. And then you go in and do your discectomy, and end up with something that looks like this, where that's not working anymore. So you've got the edge of your dura here, your nerve root here, and the disc down here. And then you put in your cage, come out and do your instrumentation. So up until recently, I've always done instrumentation using fluoroscopy. So you do a bullseye technique, put your K-wires down, dilate down, tap, put your screws in, run your rod through, and tighten everything down and end up with something that looks like that. So that's how I've done my T-lifts for the last 20 years. What we're doing now is we've returned to endoscopy. We started with endoscopy in 2002. It was a very small tube. It was a really bad camera, and it was technically very hard. So we switched to microscope, or I usually use loops, actually. And now we're doing an image guidance and robotics. So I wanted to show you the system I'm using now. It's called Telegen. It's got a number of advantages. It's got a disposable part, and it's got a small reusable part. It's got a great 4K monitor. It's got a camera control system. So when I change the angle of my tube, all I have to do is press a button, and the camera automatically changes the orientation. So I always know exactly where I'm working. One of the big problems in doing endoscopy originally was that you'd always get schmutz on your lens. You know, take your lens out, clean it, put it back in. This has a really neat automatic washing and drying system, so you never have to take your camera out. And the camera we have now is phenomenal, as you'll see in a few minutes. So this is what the disposable part looks like. One other neat thing about this is, in our original tubes, it was just a defined length. So if you had a really fat patient, you couldn't get it down to the bone. You had to make a bigger incision, retract the sides, stick it way in. Or if you had a really skinny patient, you were still stuck working through a long tube. And the longer the tube, the harder the operation is technically. So this is a tube that you can cut to the exact length that you need because it's made out of plastic. So this is our camera. It's a 22-degree camera. It fits right inside a 15-millimeter tube, and it gives you a 70-degree angle of view. It can be patient-mounted, so you can put in a pedicle screw and mount it right to the patient, so you don't have to have a table mount. But if you want to use a table mount, you can do that as well. So as you can see, I had my amphetamines the day I made this video. So this is the washing system. And actually, I don't think this is me doing this operation. It's probably my son. wonder if we could speed this up. No. At any rate, we'll move on. You get the idea. It's a little bit too long of a video. So now I'm working through a 15 millimeter tube, and that gives me very limited access to the disc itself, right? Unless I want to angle the tube all kinds of different ways. So you got to figure out what are you going to do, how are you going to do your discectomy? So we developed an instrument that we call Orbit, which goes into the disc space, and then as you rotate it, it sweeps up and down and does a complete discectomy faster than anything I've ever seen, and gives you an absolute, annulus to annulus discectomy in a couple of minutes. And then we still got to put a cage in, right? So my preferred cage is this cage. It's called Luna. It goes in straight, so I can put it in through a tiny little annulotomy, and then it curls up into a circle, and it gives you all that inner space to put all of your bone. So I can essentially get the coverage of an A-lift now through a minimally invasive T-lift procedure. And it looks like that once it's in. So for example, this is a 52-year-old man. He's got 2 years of low back pain. It's gotten much worse over the last year. He's had physical therapy and steroids. He's got a normal exam except decreased reflexes. So now I've switched from doing fluoroscopy to doing image guidance and robotics. Do I think that's better? I don't know, but it's really fun, and that's why I do it. I will tell you, though, that I feel much more comfortable with my residents now when they're doing image guidance and robotics, because once you've defined where your screw is going to go, you can leave the room. They really can't screw it up too easily. So I'm much more comfortable with my residents doing it now. So these are his pre-op x-rays. He's got motion on flexion extension. Post-operatively, he looked like this. And his CT scan looks like that. And this is immediate post-op, so you can see how much of a really nice fusion you can get with this particular system. I also have a system now, it's coned down there were too many things in the fusion set to do discectomies and foraminotomies and stuff like that, but we now have a set that we can just do. So this is a cervical foraminotomy, which we talked about earlier. Looks something like this. So this system is called Telegen. It combines several new technologies. It's got an extremely good camera. We're working through a 15 millimeter tube, so much smaller incision. It's got a 4K monitor. It's got a camera control system for orientation. It's got an automatic irrigation and cleaning system, and it can do table or patient mounting. So it makes the minimally invasive T-lift even more minimally invasive than it's been for the last 25 years. Thank you.
Any questions? Dr. Fessler, I have a question for you. So, I know that traditionally, T-lift has been called, a kyphosing procedure or whatnot because, a lot of times with especially static cages, it's harder to achieve the lordosis that we may want.
Yeah.
What's your opinion on the, newer technology like, crescent cages or expandables, because there are cages where, goes up to 22 degrees or even a little bit more at each level, right?
Yep.
So if, for most people, if you need an L4 to S1, you need like 40 degrees or so to match the PI.
Yep.
22 each level, that's, it seems adequate.
So I think there's a number of things I would say about that. The cage I just showed you, by the way, it does become lordotic. And it's about 14 degrees of lordosis. So as Chris was saying in his talk, a lot of the things we thought mattered don't matter. And I'm absolutely convinced, and we published this as well, that in adult, and by that I don't mean 30 years old, I mean adult, 55, 60, 65-year-old, degenerative disc disease for 1 or 2 levels, lordosis is completely irrelevant to clinical outcome. And the other thing we just published is that we took L4-5 T-lifts and A-lifts, and we looked at their lordosis preoperatively, and we looked at the adjacent level lordosis preoperatively for the level above 3.4 and below 5.1. And then we looked at them immediately postoperatively. And what we saw was we had increased lordosis at the 4-5 level, decreased lordosis at 3-4 and 5-1. 2 years later, they went completely back to what they were preoperatively. So is it really important in adult degenerative disc disease to create lordosis? I don't think so. I don't think it makes any difference whatsoever. And I know Sig totally disagrees with me here. We've argued this before.
Well, Rick, I've got a lot of respect for what you've contributed to what we do in MIS surgery, and I think you're right that it's hard to measure differences. Is there a difference between what you're getting with your orbit disc preparation and expandable cage and MIS approach versus an open approach is hard to measure. So I wonder what should we measure, because clinical outcomes sometimes isn't that sensitive, like pain, ODI scores, back pain, fusion rates, segmental lordosis, reoperation. What do you think is the outcome that really may show a difference? We're going to say MIS TLIF, it's an ortho and neuro crowd mixed here. It's a pediatric and adult crowd. This is one of the great things about this course. I think that in the ortho world, probably 90% of interbodies above 4-5 are being done with a direct lateral type of an approach. Whereas I think the TLIF, I love the TLIF and you love the TLIF, but most ortho people aren't using any TLIF. So if we're going to compare a direct lateral to a TLIF, what's the outcome measure you think where we might actually show some difference?
I think Chris should answer that question with the lecture he just gave.
It's really a difficult question, and it's like an abyss. The deeper you go, the more confused the picture gets. I think we will see a shift to digital phenotyping that will be coming off mobile devices and measuring everything from social functioning through like number of text messages sent, how far you travel from home, how much time you spend standing, how much do you walk. It is really another elephant in the room that if you look on any stage, like at NAS or SRS, it's one pre-op time point versus one post-op time point with no measure of continuity, no area under the curve in terms of their health improvement curves. So I think we're going to be moving toward more continuous variables to area under the curve, and I think the curves are going to be established through digital phenotyping. Not self-reported scores, and more objective metrics. I think the insurance companies are going to demand more objective metrics about functioning and return to work.
Still might not show a difference.
That's for sure.
Thank you, Dr.